biliary diseases and disorders of the spleen. Here again is Dr. Marshall.
Thank you again. As she mentioned, in this next section, we'll be talking about the two far-reaching things, biliary disease and combined with that, some disorders of the spleen. Again, have no conflicts of interest or financial interest in the topics. So what we're going to talk about first, so we'll go through the biliary structure, anatomy, choledochal cysts, basic gallbladder physiology, inflammatory conditions and the other benign disorders, infectious such as cholangitis, gallstone pancreatitis, gallstone ileus, basically all things gallstones, primary sclerosing cholangitis, and then carcinoma of the gallbladder and cholangiocarcinoma. And then we'll touch a little bit on surgical complications. Is this what to do and how to manage the complications after lab chole is good material for testing and how you would respond to those. Then we're going to switch gears a little bit into the spleen for a little bit on splenic anatomy, physiology, when to do a splenectomy, and then complications related to that. So first, the gallbladder anatomy. First question, which of the following statements regarding the vascular supply of the gallbladder is false? A, the cystic artery is a branch off of the right hepatic artery. B, the venous drainage of the gallbladder is into the right branch of the portal vein. C, the origin of the cystic artery is off of the SMA in 40% of patients. D, the cystic artery may originate from an aberrant right hepatic artery. That's right. The cystic artery is, that question should be the right hepatic artery, and it's only about 20% that are anomalous, can come off in SMA. So gallbladder anatomy, the position defines the basic anatomic boundary between the left and the right lobes of the liver. The extrahepatic portion is covered by peritoneum. It's important to understand the relationships. It's in very close proximity to the pylorus of the stomach, the duodenum, the hepatic flexure of the colon, and the right kidney are all sort of intimately involved in this area. The gallbladder itself is divided into a fundus, body, infundibulum, and neck. The cystic duct connects to the gallbladder to the common bile duct. And remember, this has the spiral valves of Heister as one of the mechanisms to prevent some flow and passage of stones. The vascular supply of the gallbladder, the cystic artery, it's a branch off the right hepatic artery. 20% are off celiac access, SMA, aberrant hepatic artery, or multiple. Venous drainage is into the right portal vein. The innervation, sympathetic or pain fibers come via the sympathetic system in the arteries. The vagus nerve and celiac ganglion provide motor stimulus. In terms of the bile ducts, the right and left hepatic will come to join as a common hepatic, and then the cystic duct, when that joins, it becomes the common bile duct. The common bile duct traverses around posteriorly to the duodenum, so it's located within the hepatoduodenal ligament, to the right of the hepatic artery and anterior to the portal vein. There's a supraduodenal, retroduodenal, and intrapancreatic portion, as well as the intraduodenal portion. There's a final distal common channel with the pancreatic duct. And then finally, the sphincter of Oddi is the structure that opens and closes to allow the efflux of bile into the duodenum. There are some anatomic anomalies that you should be aware of surgically. Those of the gallbladder of little clinical significance. They may be associated with cardiac malformations, polycystic kidney disease, or other musculoskeletal defects. Again, have little consequence. The bile ducts do have several anomalous forms, and this is important to recognize as some of these are big contributors to bile duct injury. The most common is a very long cystic duct immediately parallel to the common lymphatic duct. This one is also linked to a very common way of getting into and ligating the common bile duct. There's also arterial anomalies. 20% of right hepatic arteries arise from the SMA. The right hepatic can be very close to the gallbladder fossa and can be exposed in that. So this is, again, another area of concern to avoid getting into that either into the right hepatic artery or having bleeding, unwanted bleeding. So here are just some examples of some of the common malformations. On the upper left is normal gallbladder, you can see, with a cystic duct joining into the common bile duct. Figure 2 over on the right upper portion shows the most common anomaly, and this occurs in about 1/5 of patients, and that's where the cystic duct is intimately associated with the common bile duct and is very long. This can allow in very inflammatory states for what looks like a very short cystic duct and coming across both of these structures when they get inflamed and appear to be one structure. The last one shows a cystic duct can rotate around and join the bile duct from the other side. In addition, the cystic duct may occasionally join directly into the right hepatic duct. That's pretty rare. First on to choledochocysts. First question, the most common choledochocyst is A, type 1, B, type 2, C, type 3, D, type 4A, E, type 5, 4B, and F, type 5. Type 1, again, for testmanship, usually type 1 of something is probably the first one they found, so probably the most common. Just if you're really stuck, go with that. So overview, this is an uncommon congenital anomaly. It's most commonly diagnosed in adulthood. The pathogenesis appears to be a pancreaticobiliary maljunction there at the common duct, and it's thought that the reflux of pancreatic contents into the bile duct system causes this pathology. The ducts may join outside the duodenal wall and get that reflux. They may present in a variety of ways. This includes infection, malignancy, portal hypertension, variceal hemorrhage, cholelithiasis, and other varying presentations. It can be diagnosed on ultrasound, CT, ERCP, PTC, MRCP. You can kind of take your pick to look at these. They're classified into basically 5 types. Type 1 is a single, and the most common is a cystic fusiform dilatation of the extrahepatic bile ducts. Type 2 is a simple diverticula where the the cyst is just connected by a short stalk, and I'll show you some pictures of these. That again is rare. Type 3 is the choledococele. This is a cystic dilatation of that portion of the common duct in the inside of the duodenum. Type 4, multiple dilatations, intra and extrahepatic. When these are just extrahepatic, it's 4B. And then Caroli's disease is type 5, and that's dilatation of the intrahepatic ducts only. Here are some pictures. Again, you can see type 1, that's just generalized saccular dilatation. Type 2, a simple diverticula. Type 3, within the wall of the duodenum, the choledococele. And then type 4, where there's ductal dilatations everywhere throughout the biliary tree. And finally, Caroli's disease, or type 5, where it's confined to the liver. The treatment is very much dictated by which type of disease you have here. Types 1 and 2, a cholecystectomy with a resection of the extrahepatic biliary tree, including the choledochocyst, and then Roux-en-Y hepaticojejunostomy to reconstruct. For the type 2 or the simple diverticula, it is possible to just resect that diverticula and close the bile duct over a T-tube. Type 3, you need to do complete excision, being careful not to damage the bile duct and pancreatic duct, and then a reanastomosis of each of these must be completed into the duodenum. Type 4, again, cholecystectomy, resection of the extrahepatic biliary tree, and then a Roux-en-Y hepatico-J. For intrahepatic cysts on one side, you can do a lobectomy. If not, liver transplant may become necessary. Type 5, the biggest problem here, surgically, the goal needs to be just achieving drainage of the biliary system, whether this is through surgery or through percutaneous tubes, or both are possible. If it's isolated to one side of the liver, a lobectomy is sufficient. If it's on both sides, or there's severe hypertension, or once they get to the point of liver failure, transplant is the only solution here. Gallbladder physiology in general. So the absorption here is both water and sodium is absorbed. There is mucus secretion, which can lead to high drops and distension when the ducts are obstructed. There is some motor activity. Cholecystokinin from the duodenum in response to fat will cause contraction of the gallbladder and relaxation of the sphincter of Oddi. There's also numerous hormonal, neuro, and mechanical factors. The bile ducts themselves have no motor activity, meaning they don't peristalse or drain in any way. First on, getting to the inflammatory and all the benign conditions of the gallbladder. Which of the following is an indication for an urgent, that is within 24 to 72 hours, cholecystectomy? A, biliary dyskinesia. B, symptomatic cholelithiasis. C, acute cholecystitis. Or D, chronic cholecystitis. That's right. Acute cholecystitis. The reason I bring this up is this is different than the way a lot of us trained, where if it was cholecystitis, you cooled it off with antibiotics and came back in 6 weeks. That is no longer the recommendation. When a patient presents in the hospital with acute cholecystitis, unless there's some reversible medical condition, the gallbladder should come out that admission and as soon as possible. It only gets harder with each day that goes on. Another question, which is the strong or the strongest indication here for cholecystectomy in an asymptomatic patient? A, adenomyosis. B, 1 to 2 centimeter gallstone. C, 11 millimeter polyp. D, porcelain gallbladder. Or E, sickle cell disease. And again, we're looking for the strongest indication here in an asymptomatic patient. See, about 36% got that. 11 millimeter polyp has the highest risk of harboring cancer. We can talk a little bit about porcelain gallbladder. That was based on about a 50-patient case series out of Argentina in the 50s. There's not been a lot of data more than that to support it, but the 11 millimeter size polyp is highly indicative, especially with stones, that it may harbor carcinoma. Again, all of these are relative indications. May not be the best question. So looking at these, we got biliary colic and chronic cholecystitis, acute cholecystitis, choledocholithiasis, and cholangitis, or stones within the ducts, gallstone pancreatitis, gallstone ileus, and then PSC, or primary sclerosing cholangitis. So asymptomatic cholelithiasis, about 80% of people with gallstones have no symptoms at all, and about 2/3 of the population ends up with gallstones at some point. The risk of progression to symptoms is about 1 to 4% per year. For high-risk patients that are asymptomatic, so porcelain and calcified gallbladder is one risk factor for carcinoma. Polyps greater than 10 millimeters, especially in the setting of gallstones, should all come out. Sickle cell disease, usually if this needs to be done, it's at the time of splenectomy for some other indication. If they end up with pigment stones and will eventually become symptomatic. Post-cardiac and pulmonary transplant, for some reason, the lung and heart transplants do very poorly with cholecystitis and are at increased risk. And then hereditary spherocytosis and thalassemias, again, at the time. If you're going in to take the spleen out, you can just take the gallbladder out laparoscopically at the same time. Biliary colic, this is classically postprandial pain that resolves spontaneously. There's no fever, no leukocytosis. On ultrasound, there are gallstones, but there's no gallbladder wall thickening and no pericholecystic fluid. This differentiates it from cholecystitis. CAT scan can be used to show the presence of stones. Treatment is elective cholecystectomy. Acute cholecystitis is caused when there's inflammation due to the obstruction of the cystic duct by a gallstone or sludge. So basically nothing, no bile is coming out or going into the gallbladder. Remember that the gallbladder continues to secrete mucus and fluids, so it will become more and more distended during this time. About 50 to 75% do have a bacterial infection superimposed. These present with right upper quadrant pain, nausea, vomiting, and fever. Here the difference with this is that the right upper quadrant pain is continuous and will not simply go away. So that colicky pain is benign. Cholecystitis is a little bit more likely to present with that unremitting pain. They will show right upper quadrant tenderness, Murphy sign, which is pain with inspiration when you palpate in the right upper quadrant, and leukocytosis. On imaging, ultrasound is about 60 to 70% sensitive. For acute cholecystitis, the findings would be a thickened gallbladder wall, pericholecystic fluid, and a sonographic Murphy sign, meaning you elicit the same thing when you put the ultrasound probe in the right upper quadrant. HIDA scan in difficult cases to diagnose is 90 to 97% sensitive. This basically shows non-visualization of the gallbladder. The media given concentrates in the bile. If the gallbladder doesn't fill, you'll see an absent space while the liver and the rest of the system lights up. This can be useful, especially in those cases where you may see no gallstones or the patient's very sick and septic, and you're trying to figure out why this patient is septic. It is the gallbladder the source. It's usually helpful in those high-risk patients where you're hoping not to go to the operating room unless you're sure you have a diagnosis, or to do maybe percutaneous intervention. CT, again, is also useful for diagnosis. Treatment is IV antibiotics, bowel rest, resuscitation, and then cholecystectomy within the first 72 hours of diagnosis, unless there's significant reversible comorbidities, meaning if you've got some sort of heart disease or pulmonary disease that you can optimize and get better, these patients may be better served by getting the medical issues under control before taking out the gallbladder. Complications that we can see are hydrops of the gallbladder. This is that chronic inflammation with denuded mucosa. The gallbladder is incredibly distended, probably impossible to grasp with the graspers. It's filled with white bile or much less greener than you would expect bile. You can get an empyema, which is an abscess of the gallbladder contained. And then there's emphysematous cholecystitis. This can be due to two things. It may just be necrosis of the gallbladder and death of the gallbladder wall. More often than not, though, it's from gas-producing organisms within the wall, such as E. coli, Clostridium, or some of the streptococcal stains may show an emphysematous gallbladder without frank necrosis. Acalculous cholecystitis is secondary to gallbladder ischemia. This is usually, the classic teaching is burn patients, septic patients, patients in the ICU for a long extended course after arrest. Imaging, ultrasound, and HIDA may be useful here. Again, these patients are usually not great operative candidates. The reason they got this is because they're very sick, and going to the OR is usually not optimal. In these patients, percutaneous cholecystostomy tube may be the better answer, and then come back, and once things are sorted out, if the patient survives, then you can sort out what to do with the gallbladder. But it has to be drained in one way, shape, or form. Choledocholithiasis, this is simply the presence of stones within the bile ducts. About 4 to 11% undergoing cholecystectomy may have it. In acute cholecystitis, that can be up to 1 in 5 patients who may have actual stones in the ducts. The classic findings here are jaundice, elevated alkaline phosphatase, and total and direct bilirubin will be elevated. You can see a dilated duct on either the ultrasound, a CT scan, or MRCP. Preoperative ERCP versus lap choline with a cholangiogram and common duct exploration, or postoperative ERCP are all options here, and I'll show you next an algorithm that can be useful. So if you have common duct stones, you may have a preoperative suspicion here. If you suspect it preoperatively, it's probably a good idea to progress with MRCP. If that's positive, go on to your ERCP and attempt to get the stone out preoperatively. And then if that can't be cleared, you know that when you get in there, you're going to have to do either a common duct exploration or the like. If the MRCP shows no stones, just progress with your lap choline. For those where the IOC is positive, there are some minorly interventional techniques such as a Fogarty catheter or maybe some cholecystokinin and trying to flush the duct out. Or you can do a transcystic or an actual laparoscopic common duct if that's in your skill set. The other option here is just to leave the stone in the duct if you can't get to it and go to a postoperative ERCP. And then lastly, you may have post-op retained stones. The best thing to do here as a start is to go directly to ERCP for removal. Again, a lot of this will depend on your local resources and your skill set in sort of doing these things and how much bile duct surgery you want to be doing with the laparoscope. Next, we'll move on to cholangitis. Following a diagnosis of acute cholangitis for a patient who's non-toxic in appearance, the most appropriate initial management is A, CT or MRCP, B, ERCP, C, IV antibiotics and hydration, D, laparoscopic cholecystectomy with intraoperative cholangiogram. That's correct. Most of you got that. IV antibiotics and hydration, again, earlier in this shock lecture when we spoke, we talked about just start the hydration and the resuscitation and then figure out what you need to do to treat. So an overview, this is an infectious syndrome affecting the bile ducts. Basically, it's pus under pressure in the biliary system. Biliary obstruction leads to stasis and overgrowth. It can be either it can be primary or secondary choledochal lithiasis, and that has to do with whether these are stones that formed inside the ducts, and you can see this after a lap chole even, or whether you had stones that traveled there out of the gallbladder. Other etiologies that may cause obstruction include benign strictures, Moritz syndrome, primary sclerosing cholangitis, choledochal cysts, or malignancy. So keep in the back of your mind is why the patient may be obstructed if you can't find that stone. So the biliary system is normally sterile. The intact sphincter of Oddi prevents the duodenal contents from refluxing. There's sort of a constant efflux of bile into the duodenum, so there's a constant fluid flow out. The IgA is present in bile, which will fight infection. And there's also some bacteriostatic properties of all the bile salts. It's not a very hospitable environment for any of the bugs. It results from direct ascent of bacteria from the duodenum, so gut flora are the norm. E. coli and Klebsiella are probably the most common. Enterococcus, Enterobacter, Bacteroides, Clostridium can all make up a portion of this. Diagnosis, classically a Charcot's triad, fever, right upper quadrant pain, and jaundice due to the biliary obstruction. Reynolds Pented showed a progression of disease with altered mental status and hypotension, as well as the original 3 findings. So on the lab studies, leukocytosis, elevated alkaline phosphatase, and direct bilirubin. This can be diagnosed on ultrasound, ERCP, or PTC. ERCP has the benefit, and PTC, of providing drainage, making the diagnosis and achieving therapy. The treatment, again, is resuscitation, fluids, early IV antibiotics, and then some form of biliary drainage, ERCP, percutaneous, surgical, and then eventually more definitive therapy so that we don't get back to the same place. Moving next benign condition, gallstone pancreatitis. We'll kind of just focus on the gallstone aspect as you'll have other lectures on the pancreas. This is pancreatitis which is induced by the passage of gallstones, sludge, or microlithiasis through the ampulla of Vater. The exact mechanism is unclear here as to what's going on, but it causes epigastric abdominal pain, nausea, and vomiting. It can be associated with organ failure, systemic inflammatory response like any other form of pancreatitis. It's elevated amylase and lipase and liver function tests. This is the combination, whereas in just simple pancreatitis, you would expect your bilirubin and the others to be normal. With gallstone pancreatitis, you may see those obstructive lab findings of the alkaline phosphatase and bilirubin and the elevated amylase and lipase. Ultrasound, CT, and MRCP are, again, all useful here for diagnosis. So again, resuscitation, whether this is driven by Ranson's criteria or by Apache 2 or physiologic scores, is not important. Usually the bowel rest initially for the pancreas, supportive care. For definitive therapy, you need to get the gallbladder out so that we don't pass more stones and this doesn't happen again. In a mild disease with pancreatitis that rapidly resolves, this should be done in the hospital so you don't have another secondary event before you get back. Each time you get another episode of pancreatitis, the risk is the same of morbidity and mortality. If it's moderate pancreatic disease, waiting 3 weeks is recommended. In very severe disease, you got to give them about 6 weeks to get through the initial phase. You want to make sure your pancreatic ascites and all of those things have resolved so you're not making the operation even harder for yourself. Gallstone ileus, these are more fascinating things than something you see that often. The classic radiographic finding in a patient with gallstone ileus is A, intestinal obstruction, B, pneumobilia, C, calcified stone distant from the gallbladder, and D, all of the above. Yes, all of the above is correct. So basically what's going on in this condition is you have a mechanical obstruction of the GI tract by a gallstone, an ectopic gallstone. Usually this results from a gallstone that's large in size that has become wedged in the neck of the gallbladder. It creates ischemia and pressure necrosis of the gallbladder into the adjacent hollow viscus, and then a fistula occurs. Once that happens, the stone can get out into the GI tract. It can obstruct usually at the ileocecal valve. It can be in the sigmoid colon. It can be in the duodenum or the pylorus. When it's in those locations, it's called Bouverie syndrome. And basically what occurs here is the gallstone fistulizes into the stomach and then causes a gastric outlet obstruction. Normally, if it goes into the small intestines or the duodenum, you end up obstructing the first pinpoint of contact, which is the ileocecal valve. They'll have signs and symptoms of bowel obstruction initially. So abdominal x-rays are sensitive in about half the cases, and it's called Wriggler's triad. But basically you see pneumobilia, which is caused by the fistula presence, air fluid levels consistent with a small bowel obstruction, and an ectopic gallstone that's somewhere other than the gallbladder. Again, only about 50% present with this classic picture. CT scan is 93% sensitive for finding this. This will show, again, abnormal gallbladder with air fluid level or oral contrast into the gallbladder. Also dilated small bowel loops consistent with the obstruction, and then you should see the gallstone somewhere causing the obstruction. For these patients, resuscitation is usually required. These patients are usually pretty sick at the time of presentation by the time this has happened. At laparotomy, we palpate the entire small bowel. There may be more than one stone than the one that's causing the trouble. An enterotomy is made proximal to the impacted stone, and then it's extracted in a retrograde fashion. The enterotomy is not made before because that is in front of where you're stuck, so you end up doing more bowel damage by trying to pull it forward where it's already stuck rather than pull it back into an area it's passed through. Small bowel resection may be required if there's necrosis and pressure ulcerization at this site. The next question comes in these is, what do you do with the gallbladder in this case? Usually it is, this is a sick patient, and the degree of inflammation that allows for a gallstone to get from the gallbladder into the stomach, duodenum, or colon is very significant. So if it's a chip shot and a straightforward operation to get this done, you can do it at the same setting, but primarily this will be done in a two-stage setting. The gallbladder is really already drained through whatever fistula is there. The trick here and the most important thing is to relieve the obstruction and allow the patient to be resuscitated. Sir? That's correct. He asked if you have to go back and get the gallbladder after it's fistulized like this, and the answer is no. If they're asymptomatic, and usually these are not like healthy on-the-street patients that get this. This is your 80-year-old woman with multiple comorbid conditions who really is not in any shape for an operation. So having to go back and do all of this, once the stone is removed, the fistula may cure on its own, but it's already drained, as he mentioned, and so it's not always necessary to go back and take the gallbladder out later unless there's recurrent symptoms or a high risk for the occurrence again. Again, as he mentioned, that was argued in a surgical forum back and forth, so opinions still all over the place. The textbook's answer is you do it as a two-stage. The clinical practices probably very rarely need to go back and do this. Next, primary sclerosing cholangitis. So this is a progressive inflammatory strictures of both the intra and extrahepatic biliary system. These strictures lead to cholestasis, which leads to cirrhosis, liver failure, and death. 10 to 20% of patients with PSC will develop cholangiocarcinoma. About 70 to 80% of the patients who you find this in have IBD, most likely ulcerative colitis. However, less than 10% of IBD patients go on to get primary sclerosing cholangitis. There's other associated autoimmune diseases. This can be celiac disease, type 1 diabetes, autoimmune hepatitis, and ankylosing spondylitis. There's a very high association with gallbladder malignancy. So cholecystectomy for any size polyp in these patients. The presentation is variable and it depends on where the obstruction is and at what level. It can present with right upper quadrant pain, pruritus, fatigue, weight loss, abnormal LFTs, and liver failure. These patients usually present with very high bilirubin, which leads to the pruritus and some of the symptoms. ERCP and MRCP can both be used for the diagnosis. Liver biopsy can be done if you want to assess for a small duct disease. If you have a normal cholangiogram, you might detect that on a biopsy. Autoimmune hepatitis, if that's found, can be treated with immune suppression such as steroids to alleviate this. There's no treatment in asymptomatic disease. No medical therapy slows the progression. You can do endoscopic or percutaneous dilatation to relieve the strictures. If there's dominant extrahepatic disease, this can be suspicious for cholangiocarcinoma, which may lead you to a resection. Liver transplant ends up being the optimal therapy once cirrhosis develops. So once that cirrhosis develops, it will progress eventually to fulminant hepatic failure and a transplant. Now looking on to malignant conditions within the gallbladder. 60-year-old female undergoes laparoscopic cholecystectomy for acute cholecystitis. The pathology report reveals gallbladder cancer with tumor extending beyond the perimuscular connective tissue, but not beyond the serosa. The most appropriate management is A, observation and close clinical follow-up, B, excision of gallbladder bed, C, excision of gallbladder bed with periportal lymph node dissection, or D, adjuvant chemoradiation. I see most of you got that. It is excision of the gallbladder bed with a periportal lymph node dissection. Observation and close clinical follow-up would be if the tumor was a tumor in situ or if it had not gone beyond the perimuscular connective tissue. We'll talk more about what to do in that finding. So again, this is mostly adenocarcinoma. Anaplastic squamous, adenosquamous are all other possibilities, melanoma. It occurs more often in females than males and more often in whites than African Americans. The incidence parallels that of cholelithiasis, so it's in about 1 to 2% of laparoscopic cholecystectomy specimens. Risk factors include advanced age into the 6th and 7th decade, large gallstones greater than 3 centimeters, calcification of the gallbladder wall, adenomatous polyps, and anomalies of the biliary pancreatic duct junction, again, like the choledochocysts that we talked about. It spreads usually by direct extension into the cystic duct, the liver, stomach, duodenum, colon, any of the bystanders. It can also spread by the lymphatics, which is why nodal dissection is required. There can be hematogenous spread, so both the lung and the brain, and then the peritoneal surface will also become affected, usually at your surgical wound or your port sites. Median survival is less than 6 months. This is a bad actor. Overall, 5-year survival is less than 5%. So the staging, tumor in situ is just carcinoma in situ. 1A invades the lamina propria. 1B invades the muscular layer. T2 now invades perimuscular connective tissue, but does not go beyond the serosa. T3, it perforates the serosa and invades something adjacent, and then T4, you're into the main portal vein, hepatic artery, or 2 extrahepatic organs and structures. Again, N0, N1, whether there's lymph nodes or not, and then M0, M1, whether there's distant metastatic disease or not. In terms of staging, again, this is not, no one's going to ask you to define the stage of a patient presented on all of these, but usually T1 is stage 1, T2 is 1B, T3 is 2. You can see this advances pretty quickly and follows the normal nomenclature. By the time you have nodes, you're always into stage 3. Distant mets is stage 4. You can have suspicion before surgery. Again, a dominant mass in the gallbladder, diffuse thickening of the gallbladder, or polyps greater than 10 millimeters may all lead you to a preoperative suspicion of this. Fine cut CT or MRI can help to make the diagnosis. CEA and CA 19-9 are frequently elevated, but That's not going to be something that makes or breaks your diagnosis. There's no role for biopsy, as you can potentially seed and turn a resectable case into a non-resectable case. So unless it's going to change management, you don't need to stick a needle in these things. Percutaneous biopsy, again, only if it's going to change what you do. So there's all sorts of ways that this may be found. So if you're discovered at the time of surgery, if the cholecystectomy is done, you may proceed to definitive therapy if you know the stage. Again, that's going to be kind of hard to get that kind of detailed pathology that you know, whether it's a T1 or T2. If it's far enough that a frozen tells you need to do that wedge resection, you can go on. You can just do nothing at this point and recover the patient, stage the patient, and return for definitive care. If the cholecystectomy is not done, no dissection or biopsy, laparoscopic staging, stop the case, go ahead and figure out what you're doing, and then go back and do the definitive operation. If dissection has begun, you can convert to open, resect with a rim of liver tissue, send to frozen, and proceed with definitive care. If you don't have the local resources or the skill set to do a major hepatic resection, you can just stop dissection if you still have an intact, duct and artery. And send the patient on for definitive care and just leave it at that. Cholecystectomy for polyps, again, larger than 10 millimeters, any size and setting of cholelithiasis, and patients with PSC should have this done. For tumor in situ or 1A, they have an 85 to 100% 5-year survival. It's an incidental finding on the pathology. Cholecystectomy with free margin is all that is needed. And there's no difference in the open versus lap approach, although you very much want to avoid gallbladder perforation and spillage of potential cells into the abdominal cavity. For T1B or T2, again, you can see the lymph node metastasis rate goes up to 15% and then 40 to 80, and it also increased risk of extension in the liver. On these, the treatment is radical cholecystectomy. This includes a cholecystectomy with 2 centimeters of liver parenchyma, as well as a lymphadenectomy in the portal, gastrohepatic ligament, gastroduodenal ligament. Again, so we have the very minimal incidental finding. Just leave it alone. When we move on to just a little bit more advanced on the tumor staging, you need to go back, get that 2 centimeter rim of hepatic tissue and a node dissection. Yes, sir? It's still pretty bad. We'll go over some of the outcomes here again. But you have a chance with the T1B lesions, especially of getting a resection for cure. When you start moving into T2 with all the lymph node mets, you may just be prolonging life a little bit here. But you don't know that initially, and you can get resection for cure in some of these early lesions, if you're lucky to find it then. For T3 and T4, you need diagnostic laparoscopy to look for metastatic disease. This is treated with a radical en-bloc resection with negative margins. No survival benefit to debulking. So really, with metastatic disease or large volume disease that you can't get all of, there's really no point in going because the survival is equally low. 85% recur at a distant site, and 15% will have local regional recurrence. As far as adjuvant chemoradiotherapy goes, there's no randomized data that show improved survival with either chemotherapy or radiation. Some studies suggest there may be a little bit in T2 greater or N1 disease, but again, just suggestive. Gemcitabine cisplatin therapies may have some palliative benefit, but again, no cure. Cholangiocarcinoma, equally also a bad actor. Which of the following is not a criteria to suggest unresectability of a cholangiocarcinoma? A, encasement of the portal vein proximal to its bifurcation. B, unilateral hepatic artery involvement. C, bilateral secondary biliary radicals. Or D, distant metastatic disease. Again, which is not a contraindication. Yes, unilateral hepatic artery involvement. Again, here's a little bit of testmanship. If they're going to the trouble of telling you two sides or one side and they specify that it's unilateral, again, they're probably trying to signal you a little bit that this may allow for resection. The majority of these are sporadic. Risk factors include primary sclerosing cholangitis, choledochocysts. Asian descent is at twice the risk. Males are at 1.5 times the risk. Other bacteria, parasites, toxins, and hepatitis C are all linked. There's three anatomic types. First is intrahepatic, where the bile ducts are affected within the liver. The second is the Klatskin tumor or perihilar tumor. And then finally, the distal cholangiocarcinoma. For presentation, for intrahepatic, they may only have abnormal LFTs, and that may be all that you see. This will present with painless jaundice, Crevassier's sign, anorexia, weight loss, fatigue, and abdominal pain. 90% of the perihilar and distal present with obstructive jaundice. And so the bili is greater than 10 and is average 18 at presentation. This differential includes benign strictures, PSC, choledocholithiasis, and Moritzi syndrome. Diagnosis here, MRCP is superior, as you'll not only see the ductal anatomy internally, but see the extent of disease throughout. ERCP and PTC can also be used. Staging, EUS will assess resectability, and you can perform an FNA. CT can evaluate for metastatic disease. The staging at T1 is tumor confined to the bile duct. T2, the tumor invades beyond the wall of the bile duct. T3, invading liver, gallbladder, pancreas, or unilateral portal vein or hepatic artery. And then finally, T4 invades in the main portal vein, hepatic artery, colon, stomach, duodenum, abdominal wall. These are aggressive tumors. Again, the lymph nodes, yes or no, N0, N1, and the same with distant Mets. The staging, again, this is, you can see it's pretty aggressive because by the time you get any lymph node, you're at 3C, and then T4 is any degree of metastasis. The treatment is resection to negative margins. For distal tumors, this may involve a Whipple procedure. Resection with Roux-en-Y, biliary, enteric reconstruction for the perihilar or Klatskin tumors. The median 5-year survival here is 30% for perihilar, 27% for distal. This here is something for your review as you get closer, but it looks at reasons for not resecting. Again, someone who's medically unfit, distant metastatic disease, extensive local involvement where you get bilateral encasement of portal vein, hepatic arteries, or secondary biliary radicals. Also, you have to gauge how much liver remnant you'll have. If there's less than 2 contiguous segments or less than 30% functional liver remnant, that is a contraindication to hepatic resection. For distal lesions, it's medically unfit, and again, extensive lymph node disease in distal Mets or significant involvement of the SMV, SMA, or the common and proper hepatic arteries. As far as adjuvant chemoradiotherapy here, there's no randomized data have demonstrated improved survival with either chemo or radiation. There may be a benefit for chemoradiotherapy for positive margins or for lymph nodes. For palliation, photodynamic therapy can work. Biliary stenting can at least relieve some of the obstructive jaundice symptoms, and a biliary enteric bypass may be helpful for some disease. Median survival is less than 12 months. So again, another bad actor. Now we're going to switch gears a little bit on the gallbladder and talk about surgical complications. This is a common procedure, therefore you can see complications presented clinically, and how are we going to manage some of those? So here's a question. A 40-year-old woman is discharged home after undergoing uneventful lap chole for acute cholecystitis. She presents on post-op day 2 with diffuse abdominal pain, nausea, and vomiting. HIDA scan reveals a bile leak. The most appropriate next step in management is A, percutaneous drainage of biloma only, B, ERCP with sphincterotomy and stent placement, C, diagnostic laparoscopy and repair of the bile duct leak, or D, laparotomy and repair of the bile duct leak. That's right. ERCP, sphincterotomy, and stent placement is the first step in taking care of these problems. So an overview, wound infections, this is a clean contaminated case. When you're getting into cholecystitis and others, you might see an increased incidence. Bleeding and hematoma are rare. This can either be from the gallbladder bed or from the port sites. Bowel injury related to either the trocar, thermal injuries, especially if the duodenum is very close to the gallbladder, and also cutting and tearing injury related to pulling or manipulating either the colon or the duodenum to get it off a highly infected gallbladder. Retained choledocholithiasis occurs in about 1% of the patients. Spilled stones can occur in up to a third of patients. Again, this can be an infectious risk later on because these stones may harbor infection, source of pain, granuloma. So you want to attempt to not spill any of this. Bioleaks occur in about 1% of patients after the operation. Hydroscan, it can be used for diagnosis. This will show either extravasation of the contrast or the uptake material into the gallbladder fossa. This can be either ducts of Luschka or cystic duct stump leak. Usually ducts of Luschka, these are just really more superficial ducts that are probably got into on a cholecystitis or another case where the plane wasn't quite clear between the gallbladder and the liver, and you got into the liver a little bit. You can sometimes see these biliary radicals causing a leak later on. Treatment is ERCP with sphincterotomy and stent placement. Usually taking away that pressure and getting the bile under less pressure in the system will allow spontaneous resolution of the leaks. If there is a biloma that's causing symptoms, percutaneous drainage will help. Again, it's the stent placement in the end that will cause the relief of pressure and allow healing. Also now moving into the bile duct injury, the dreaded complication for general surgeons of this procedure in general. So there's a Strasbourg classification. It's not important that you memorize the exact stages here. A is just cystic duct or duct of Luschka leak. B is partial occlusion of usually the aberrant right hepatic duct. C is transection without ligation of a right hepatic duct. D is a lateral injury only, partial thickness to a major bile duct. And then stage E moves on to the bismuth classification. So here is Strasbourg, A, B, C, and D. You can see here A, you just either have the cystic duct or the liver bed or leaking bile. In the other portion of the right hepatic duct, and B has been ligated and cut. In C, it's not completely, it's ligated only on one end, so the bile leak is coming back from that aberrant right hepatic. And in D, you can see here is a lateral injury cut into the common bile duct or common hepatic duct. Bismuth classification has to do with where you end up with a common duct stricture. If there's more than 2 centimeters of stump, that's a 1. If there's less than 2 centimeters of stump on the common hepatic duct, that's bismuth 2. Bismuth 3 is where you've got it all the way up into the hilum, and there's no residual common hepatic duct at all. 4 is hilar stricture involving the confluence and a complete loss of communication between the right and left sides. And then finally, involvement of an aberrant right sectorial hepatic duct alone with common hepatic duct stricture. Occasionally there's a third, you look on that IOC from the left and the right, there can be an aberrant or accessory right that perfuses a good deal of the liver. This can be missed on that IOC because you've seen what the two you were looking for. The hallmark here will be an IOC that doesn't show you a good portion of the liver despite having a left and right duct. Here again, those can be seen visually. E1 and E2 have to do with whether there's more or less than 2 centimeters. Again, this is possible to fix with biliary enteric, just anastomosis. E3, you can see it goes all the way up into the confluence, but there remains some communication. E4, we go up and the confluence is gone and there's no communication left to right. And finally, type 5, you can see there's a left, there's a right, and there's another right sectorial duct that's been ligated. So the treatment will depend on the type of injury. Usually you need a biliary enteric reconstruction with Roux-en-Y hepaticojejunostomy. If you identify it intraoperatively, it should be repaired as soon as possible if you have the skill set. It should probably, some of the literature suggests it should be repaired by someone who repairs these injuries commonly and not the surgeon that caused the injury. Not that that surgeon can't do it, but after a common duct injury, it's probably The studies show that the emotional toll and everything else going on, it's probably better to bring in your liver expert or partner to go ahead and do this and not just keep perseverating at a procedure after this. Delayed repair can be done if it's identified post-op or in an unstable patient. Basically, you need to control the bile leak. If you get to that situation, you've got a big ductal injury, you're going to have to transport them. Just leave drains in there and leave it drained widely so that will at least not prevent the bile, and then you can get them somewhere where they can do more. You want to treat any sepsis and then eventually define the anatomy. So again, on the biliary, knowing those patients who've done lap chole and show up 2 days later is great fodder for questions. What are you going to do if they have that recurrent pain? How are you going to evaluate them for those injuries? And then how would you reconstruct? All make great fodder. And then some of those minor things, the choledochocyst and PSC, maybe lesser. Again, on PSC, that tie-in with ulcerative colitis is very important. If you start to see those combinations, start to make that linkage in your mind, is that maybe where the question is leading you. Why don't we pause here at biliary and answer some questions if there are any, and then we can switch gears into a short lecture on the spleen. Yes, sir. That's going to. He wants to know what you do if you discover the injury postoperatively. Do you wait 6 weeks to fix it? That's a possibility if it's adequately drained. A lot of times that injury may allow stenting. If you have somebody who's excellent with ERCP or PTC, sometimes they can do a rendezvous procedure or get across that with a stent and allow it to heal in secondarily, which may buy you a lot of time for that reconstruction. So it's going to depend really on the nature of the injury and how inflamed and how big a mess it is in there, as well as have you controlled the bile leak or not. As long as it's controlled, you have time. All right, we'll move into the spleen. Again here, not a lot on the spleen anymore. This is probably one area that's changed. Splenectomy is becoming less and less common, as not nearly as often indicated. So, anatomy question. Which of the following is the most common location of an accessory spleen? A, the left scrotum. B, gastrohepatic ligament. C, splenic hilum. D, splenocolic ligament. Usually at the splenic hilum. All of these other locations are possible. They're just not the most common. So the spleen is a mesenchymal differentiation of dorsal mesogastrium embryologically. It weighs about 75 to 100 grams in adults. It again is located in the left upper quadrant. It approximates closely to the left diaphragm and the rib cage, and occasionally will have actual notching related to that. That becomes important in trauma cases. If you see 3 or 4 rib fractures over there on the left, be thinking splenic laceration because of that close and intimate involvement. It's also very closely associated with the tail of the pancreas, the left kidney, the colon, and the stomach. Spleen is class and size. A normal spleen is about 7 to 11 centimeters long. 12 to 20 would be a moderate degree of splenomegaly. 21 to 30 centimeters, massive. And a megaspleen is anything that's more than 30 centimeters. That one you should be able to pick up on physical. Suspensory ligaments, it's held in place by numerous attachments. The gastrosplenic ligament is where the short gastrics are, as well as the gastroepiploic vessels. These are important both when you're doing a splenectomy and finding all of these and identifying. Also, technically, this can be a source of injury. If these are taken too close to the stomach, occasionally the suture will cause gastric perforation later down the road if the care wasn't taken to get enough space. You then have the splenophrenic, where it's held onto the diaphragm, splenorenal, which includes the splenic vessels and the tail of the pancreas, and a splenocolic. Again, splenocolic is more important for colectomies and how certain problems in mobilizing that splenic flexure can lead to splenic injuries iatrogenically. The vascular supply has a variable course. It's usually a very twisting artery. It's a splenic artery is off of the celiac trunk. Its superior, medial, and inferior polar branches to the spleen. There's two types of distribution of this. You have a distributed anatomy, which is about 70% short trunk, 6 to 12 branches, 3 to 13 centimeters from the hilum, and it covers about 75% of the surface. So basically short trunk and then lots of branches heading at the spleen. The matterstral bundled is a much longer base of the splenic artery with only 3 or 4 branches that are much shorter, and it usually only involves about 25% of the hilar surface area of the spleen. These are a little bit easier to take out simply because you don't have near as many vessels or have to get as proximal or, on the artery. Accessory spleens are present in about 14 to 30% of patients. This is much higher in patients who have hematologic disorders. This is important because in many of these, leaving even a small residual spleen will result in a failure of your surgical cure. They were commonly in splenic hilum, over half, and then the splenic pedicle, the omentum, the splenorenal ligament in the tail of the pancreas, splenocolic ligament, and the pelvis or scrotum in less than 1%. So looking at normal physiology, what does the spleen do? The spleen is responsible for which of the following functions? A, fetal hematopoiesis. B, filtration of the circulating blood. C, production of opsinin, properdin, and tufsin. Or D, all of the above. That's correct, all of the above. So at first in fetal hematopoiesis, before the marrow kicks in, blood is made in the liver and the spleen. In the adults, it's more done as a filtration mechanism for circulating blood. Normal and age red blood cells pass through here. As the red blood cell becomes less deformable, it's more likely to get hung up in the spleen and broken down as it senesces. Abnormal granulocytes, both normal and abnormal platelets are filtered here. Any cellular debris is brought out. You can see pooling of blood and sequestration, especially of platelets, when you get splenomegaly and other pathology. It also produces opsinin, properdin, and tufsin, and this is important. These are little handles or proteins that are placed on encapsulated bacterium to allow the immune system to better attack. This becomes important in post-splenectomy patients. So hypersplenism, this is an accelerated removal of any or all of the circulating cellular elements of blood. You can have excessive splenic destruction, production of antibodies that may result in destruction of the cells. Splenic inhibition of the bone marrow may occur, causing a failure of maturation and cell release. Anemia is common. About the average red blood cell spends 2 out of 120 of its days of life inside the spleen. Cell injury will delay transit and splenic transit time. Age and damage RBCs are phagocytized by the splenic macrophages, and iron and everything returned to the system. Leukopenia can result. Neutrophils can be removed as rapidly as 6 hours after they become mature, so this can become a problem. And then thrombocytopenias. 1/3 of platelets are sequestered in the spleen. There can be immunologic alteration to the platelets, resulting in sequestration or destruction, and that's common in ITP. Or it can be sequestered due to a vascular encroachment by subendothelial collagen in TTP. Diagnostic considerations. On physical exam, about 2% of normal people you can feel a spleen. Percussion may show you dullness if the spleen is enlarged. You may feel palpable notching on the spleen as it enlarges as well. Labs, you can check your CBC as part of diagnosis to see what the spleen exactly is doing. Plain films are not terribly helpful, although if the spleen is getting huge, you will see this. Or you may see an absence of normal bowel where it's supposed to be because the spleen has taken that space. CT and MRI are going to be your best. You can see the size, cysts, abscess, or tumors that are present. And then technetium-99 sulfur colloid is taken up by the reticuloendothelial system, which is a better way of looking at the spleen. This is, again, that radio scanning might be useful if you're looking for that accessory spleen that was missed or some reason why your surgery didn't have the intended results. So in splenectomy conditions, we usually take this out for a rupture and hematologic disorders, and that's really what it's become limited to. It's no longer part of routine staging for Hodgkin's disease. The enzyme deficiencies are no longer an indication. A whole lot of these things now have medical treatments that we took the spleen out. So penetrating trauma, either abdominal or thoracoabdominal or flank. If there's associated injury, that may be important reason to go. Remember, in non-penetrating blunt injury is probably more common, just as we see less penetration. It can be iatrogenic, again, remobilizing the colon or some other tumors can get into splenic bleeding. And then spontaneous with some of the hematologic disorders, AML, CLL, polycythemia vera, or the hemolytic anemias may just result in a spontaneous splenic rupture. Occult trauma can occur. Sometimes these patients form big pseudoaneurysms and don't recall the antecedent trauma. Malaria, infectious mononucleosis, sarcoid, these can result in a very large spleen, which can also spontaneously rupture. So for abdominal exam, again, chest may not be helpful. That will be helpful if you see a lot of rib fractures that look like they're very displaced over there on the left. You should be thinking about the spleen, especially in a hypotensive patient. Fast or ultrasound within the trauma bay is probably your best bet for finding out if there's blood in the abdomen. It's not very specific for the source. So you can see blood around the spleen that's from the liver, blood around the liver that's from the spleen. So that fast won't tell you which organ's injured necessarily, but will tell you if bleeding is the source and it's in the abdomen. We grade according to injury severity. Non-operative management includes bed rest, hemodynamic monitoring, serial exam, serial hemoglobin, and angiography. There is now a role in non-operative management for interventional radiology and for embolizing the spleen. This is usually in high grade, maybe a grade 4 or grade 5 spleen, either with active extravasation, and that would usually be in the stem. You have a splenic injury, normotensive patient, they're extravasating, or they have a large pseudoaneurysm, you can go to IR and safely embolize the spleen to take the pressure head off and preserve the spleen at that time. So indications for operation, hemodynamic instability. If the patient's hypotensive and you think there's a splenic rupture, you got to go. Just get to the operating room. Other associated intra-abdominal injuries, if you've taken enough trauma to lacerate the spleen and there's a high chance you've got other injuries in there you need to take care of. Evidence of continued bleeding, that means you may have taken on that non-operative management. Although they're stable, they're getting into more than 2 units of blood transfused, you're probably not likely to stop. Again, IR may be a consideration here in the stable patient. Don't take an unstable patient to interventional radiology or CAT scan or anywhere. Take them to the OR. There's some debate over splenography versus splenectomy. Because we're doing splenectomy on so few patients, it's usually advanced injuries. So splenography is usually a thing of the past, because these are now, instead of going in with every single person with a drop of blood, where you can just fix a little lac, by the time we get to the OR now, they're hypotensive, they don't have time for a bunch of mesh wrappings and splenography. So you don't see a whole lot of that, just because by the time a patient meets criteria to be in the OR, the spleen is too badly damaged to try to do a splenography. There's some indications people used to do reimplantation of splenic tissue. This didn't work. It's insufficient volume to do what it needs to do or help with the encapsulation. It does not prevent the post-op complications. Question, which of the following is not an indication for splenectomy? A, hereditary spherocytosis. B, idiopathic thrombocytopenic purpura, or ITP. C, myeloproliferative disorders. D, glucose 6-phosphate dehydrogenase deficiency. That's right, it's G6 phosphate deficiency. The deficiencies are no longer an indication for splenectomy. So erythrocyte disorders, these come in many shapes and sizes. The most common is hereditary spherocytosis. This is an autosomal dominant trait, symptomatic familial hemolytic anemia. It's a defect in the erythrocyte membrane that causes it to take on a sphere shape rather than the normal indented shape. The spherocytes are unable to pass through the spleen as readily, so they're much more likely to be destroyed and sequestered there. You can see this on peripheral blood smears by the presence of abnormal red blood cells. Because of all this breakdown, pigmented stones and gallstones are common. So the treatment here can be splenectomy and cholecystectomy. Other hemolytic anemias, again, ovulocytosis, elliptocytosis, stomatocytosis, just all the similar, just random shapes in the red blood cells that change its conformation and don't allow it to pass as readily through the spleen. Thalassemias are another abnormal production of the alpha or beta hemoglobin change. The more severe form is thalassemia major. This can cause splenic enlargement and sequestration. This splenectomy will decrease the need for transfusions in these patients. For painful splenomegaly or a high transfusion requirement, that is the indication for removing the spleen. Unfortunately, these patients are at higher risk than the rest of splenectomies for overwhelming sepsis following the splenectomy. Again, in a clinical scenario, likely to describe someone who's either in these splenectomy cases who's failed multiple medical management or has high transfusion requirements. Those are going to be those indications, or has pain that's intractable for doing a splenectomy. Sickle cell disease, again, this is an abnormal shape of hemoglobin A resulting in hemoglobin S. The RBCs are, again, rigid. They can have sequestration crises, low saturations, eventually the spleen autoinfarct. So splenectomy is not always required here, but if they get a sequestration crisis, splenomegaly or hypersplenism, massive infarction, they may need to have a splenectomy. Usually autoinfarction is a slow process. By the time you get there, it's just taking care of itself and doesn't need to be done. However, if they have a massive infarct, this is going to be hugely painful and may require surgery. In idiopathic autoimmune hemolytic anemia, for patients with warm antibodies that are refractory to steroid therapy, then a splenectomy is indicated. Again, just be on the lookout that the indications for splenectomy now are high transfusion requirements usually and failed medical management. Almost everything that used to go straight, except for trauma, almost everything that used to go straight to splenectomy, now there's some sort of medical management to attempt. So ITP, idiopathic thrombocytic purpura, this is an acquired disorder. It's destruction of the platelets exposed to circulating platelet autoantibodies that are produced by the spleen. They can cause sequestration of the sensitized platelets within the spleen. Diagnosis, you see low platelet count, normal or increased bone marrow megakaryocytes, meaning the marrow is really trying to make more and more platelets, but you have a low count anyways. It's an absence of a systemic disease or medications or something else, hence the idiopathic. These patients have a normal clotting time, but prolonged bleeding time. So medical therapy, 80% of children will recover on their own from ITP with nothing. Steroid therapy is helpful. High-dose IVIG, plasmapheresis, and rituximab are all options now for treating ITP. So basically, no response to medical therapy or intracranial bleeding due to low platelets would be an indication to proceed to splenectomy. So life-threatening hemorrhage due to the low platelets or no response to all these medical therapies. Thrombocytic purpura, this is again fever, purpura, hemolytic anemia. This can have neurologic manifestations and renal disease. Plasma exchange is effective for 70 to 80% of patients, just plasmapheresis. Again, splenectomy for disease resistant to plasma exchange or recurrent disease. Some of the white blood cell disorders that have been indications, hairy cell leukemia. This was an indication in the past. Now purine analogs have replaced splenectomy for this. This is like azathioprine type drugs have removed the need in this case. And then Hodgkin's disease, non-Hodgkin's lymphoma, only again if there's splenomegaly or hypersplenism. There's no role for staging lymphomas of just doing a routine splenectomy. Some of the myeloproliferative disorders, polycythemia vera, thrombocytopenia, and primary myelofibrosis, CML. Again, portal hypertension, splenomegaly with symptoms, transfusion dependence, severe thrombocytopenia or hypersplenism would be your indications to take the spleen out. Cases where splenectomy is not indicated anymore are these deficiencies, so hereditary high red cell phosphatidylcholine anemia, non-indication, and glucose 6-phosphate dehydrogenase deficiency is not an indication. Moving now into some of the infectious and other complications in the spleen. Splenic cysts may occur. These can be true cysts, which have an epithelial lining. These are parasitic due to echinococcus. Both splenectomy and medical management are part of treatment. It can be congenital or non-neoplastic if it's non-parasitic. There's also secondary or false cysts, and these are the ones that occur after trauma, after pancreatitis, after an infarct, so they appear to be cystic structures, but they do not have the true epithelial lining. For asymptomatic cysts below 5 centimeters, these can be managed conservatively and may require no treatment. For over 5 centimeters or symptomatic, you can do a total or partial splenectomy or fenestrate and just allow the cyst to drain into the cavity. For splenic abscesses, these are usually secondary to hematogenous spread from other sources. Fever, fatigue, abdominal pain, leukocytosis are all part of this. CT can be diagnostic for splenic abscesses. Most common are gram-negative forms. There are some gram-negative fungal cultures. Splenectomy is the definitive cure here. Percutaneous drainage is possible, but it has a very high failure rate of up to 50%. So it is, in a very sick patient, septic patient, it is doable, but it's very likely not to be definitive there. So for the actual performance, laparoscopic for a lot of these myeloproliferative disorders or these planned splenectomies is possible through either a lateral or anterior approach. Post-operatively, you'll see Howell-Jolly bodies, Heinz bodies, Pappenheimer bodies. These are all sort of the cellular debris such as DNA and iron and other things that the spleen used to clear up and now will remain part of the cells, remain in the smear. Platelet count should normalize within about 2 days after splenectomy and should peak at about 2 weeks. Remember, it's common to have a leukocytosis after splenectomy, so a white blood cell count in the 14-15 range is pretty common for a couple weeks and doesn't mean that there's an abscess or other things necessarily. Complications, left lower lobe atelectasis is common due to taking down all the ligaments. Subphrenic abscess in this cavity will occur, hematomas, thrombocytosis, and then splenic and portal vein thrombosis. And then finally, overwhelming post-splenectomy sepsis. So looking at these complications, OPSI, this is due usually to encapsulated organisms. Remember, the opsonization and properidin and tuftin are attached to the capsules of these organisms, and then the immune system is able to better fight them and find them with the white cells. These are pneumococcus, H-flu, and meningococcus. All of these have vaccines available. The rate is higher in children than in adults, and it can be really higher if under 5 years. Its highest risk is in the first 2 years after splenectomy. If you're planning an elective splenectomy, you can give all of these immunizations 2 weeks preoperatively is the goal. If you can't do it then, it should be done 2 weeks postoperatively. As a rule in the textbook, in practice, I know for most trauma patients, we give it before they leave the hospital because they don't show up. You can't, unless you can guarantee follow-up, you want to make sure that they get these after your emergent splenectomy. You want that to be pretty much guaranteed. But again, the textbook's 2 weeks preoperatively if you know you're doing the spleen, 2 weeks after the operation if you weren't aware. Prophylactic penicillin use and keeping that bottle of penicillin is no longer the standard of care. I've been at no trauma centers that have patients walking around with a script for penicillin. You really just need to counsel these patients that if they get a fever, if they get any signs of infection, they need to present to the hospital quickly and not linger at home for a couple days and let things get out of control. Oh, we got finished a little early there. Questions? Sir? He's actually asking about, for damaged spleens, doing a splenography using a mesh pouch, like taking a piece of Vicryl mesh and just sewing it around the spleen and the splenic hilum. That was something that was done years ago. I don't know anyone who's still doing that. And again, the indications for splenectomy have become so lessened that they're usually a hypotensive patient with a badly damaged spleen, because a lot of these grade 2 and 3 lesions don't ever get to the OR, and those are the lesions that were best suited for a splenography or doing that with the bag. Okay, a little bit longer break. Thank you.